What is the interstitial disease? It is a disease consists of tissue inflammation, progressive scarring, reduced oxygen breathing difficulty to the lungs. So, tissue inflammation in ILD. ILD trigger chronic inflammation in the interstitium, the connective tissue network surrounding alveoli and blood vessel. This is characterized by infiltration of inflammatory cell including lymphocyte, macrophages and neutrophils. Progressive scarring. Because of the persistent inflammation activates myofibroblasts and excessive collagen deposit, leading to irreversible fibrosis that replace normal lung architecture with dense, stiff scar tissue that cannot expand properly. Now the reduced oxygen transfer fibrotic thickening of the alveolo-capillary membrane increases the diffusion distance for gases, which severely compromises oxygen transfer into pulmonary capillaries and results in decreased blood oxygen saturation or blood oxygen supply, known as hypoxemia. Now, difficult breathing or breathing difficulties. The combination of restrictive lung physiology, that is a reduced lung volume and decreased lung compliance and impaired gas exchange manifest as progressive dyspnea initially during exertion but eventually occurring at rest in an advanced disease. So now let's start with the type of interstitial lung diseases. Interstitial lung diseases comprises of over 200 distinct disorders, each with unique causes, treatment and prognosis. So we are going to talk on the most 5 commonly encountered types of ILD, and this include first is a idiopathic pulmonary fibrosis, most common and severe form of with unknown cause. It is characterized by progressive scarring, primarily affect adult over 60 years, median survival of 3 to 5 years post diagnosis. Symptoms include persistent dry cough, progressive breathlessness, and clubbing of the fingers. Diagnosis typically require high resolution CT scanning and sometimes surgical lung biopsy. Treatment options include antifibrotic medication like perfindon and nintedanib, pulmonary rehabilitation, and lung transplantation in appropriate candidate. Next is a non-specific interstitial pneumonia. Features more uniform inflammatory pattern throughout the lungs. Often respond better to treatment than IPF, interstitial pulmonary fibrosis. Some cases associate with connective tissue disorder or medication exposure. Present with gradual onset of breathlessness and cough over months. Radiographically shows ground glass opacities and reticular patterns, predominantly in lower lung zones. Treatment typically include corticosteroid and immunosuppressive agents. Higher survival rate, substantially better than interstitial pulmonary fibrosis at approximately 80%. Then the next is a hypersensitive pneumonitis. It is triggered by repeated allergen exposure such as mold, bird protein, or chemical compounds. It can become chronic with continued exposure. It leads to irreversible fibrosis in 5 to 15% of cases. Acute form present, acute form present with flu-like symptoms hour before exposure. Chronic form develops insidiously or slowly with progressive dyspnea and fatigue. Environmental avoidances is the cornerstone of management, supplemented by corticosteroids in more severe cases. Early diagnosis and allergen removal can lead to complete recovery in acute cases. Now we'll start with the sarcoidosis. It is characterized by granulation formation in multiple organs, affecting lungs in over 90% of the cases. Most prevalent in adults between the age of 20 to 40 years, with higher incidence in African Americans and Northern European. Many patients are asymptomatic with abnormality discovered on routine chest imaging or screening. Symptomatic patients may experience cough, shortness of breath, fatigue, and extrapulmonary manifestation. Diagnosis often require demonstration of non-caseating granulomas and exclusion of other causes. Up to 30% of cases resolve spontaneously, while others require corticosteroid or steroid-sparing agents, and the last one is a connective tissue disease, interstitial lung disease, that is a CTD-ILD, associated with autoimmune condition like rheumatoid arthritis, systemic sclerosis, and lupus. Lung involvement occurs in 15 to 85% of patients with connective tissue disease, significantly affecting prognosis. Manifested by Manifestation vary by underlying disease, with systemic sclerosis having the highest prevalence of ILD, 80%. Symptoms may be masked by concurrent musculoskeletal complaints. Treatment addresses both the underlying autoimmune disease and the lung manifestation, typically with immunosuppressive therapies. Regular screening for pulmonary involvement is recommended for patients with connective tissue disease, CTD. Early recognition and accurate classification of ILD type is crucial for determining appropriate treatment strategy and predicting disease course. Multidisciplinary discussion involving pulmonologists, radiologists, and pathologists is the gold standard approach for diagnosis. Thank you.